the other areas that we'll talk about in a little bit. And then at the end, we're going to go through all of the behavioral health sections. So how many are here for behavioral health? Oh, good majority. Okay. So we're going to do that at the end. So if people who do not want to stay for the behavioral health, we'll take a little bit of a break, and then we'll go through all of that, okay? All right. So thank you and welcome. I'm going to go through a little bit here first before we get started into all the rules and give you a little bit of understanding of where we're at and what happened with the rules here. First of all, back about 18 months ago, the state legislature charged the Department of Health Services with looking at what we have and our organizational process as it relates to behavioral health licensing and medical facilities licensing, and ask why is there a need for two licensing processes, some of which could be consistent in those processes and some that might not be as consistent in those processes. And so we were asked to really look at that and see. And so we also looked at what is the division of the Department of Health Services looking at, and what do we want as a strategic map going forward. So when we looked at that, we felt that integration of these rules was part of our strategic map. And as you can see here, we're looking at what can we do to protect the health and safety of Arizonans in Arizona. And by doing that, looking at integration of physical and behavioral health services was a key component of that. And the reason for that was because there really isn't a separation. You can't really separate behavioral health services from medical services. So we wanted to move forward in looking at that and also making sure that we protect the public health and safety. We also wanted to strengthen our public health systems and utilize all the sources that we have within the Department of Health Services to assist you as providers providing that needed service within Arizona, looking at what other services we have. We have our epidemiology, we have our tuberculosis team, we have our smoke cessation team. We have a lot of resources here in the Department of Health Services, and how can we integrate that into licensing to help and bring those services forward to you all to provide assistance to that. And then we needed to look at ADHS and the effectiveness within ADHS. And some of you we've had some verbal conversations with, and we talked about how we're doing this integration from a physical perspective. And behavioral health licensing, which was a standalone office of the Department of Health Services, has now been integrated into other programs within the department, and then those departments have been realigned. And what we have now are three bureaus. We have the Bureau of Long-Term Care, we have the Bureau of Residential, and then we have the Bureau of Medical. And behavioral health is a part of each of those depending on the services that are being provided within Arizona. So we're excited about that and want to move forward with the growth as we move forward with everything here today. And I think I've talked about this. One of the reasons that we looked at this, and this was a House Bill 2634 where all of this started, and it was established now into law. And on or before July 1, we were charged with the responsibility to reduce monetary and regulatory costs on persons or individuals. So that was our charge as we looked at these rules and looking at what's happening. And those of you who are familiar with following 20 in your behavioral health components, there were a lot of prescriptive rules in there. Some of that has been generalized and put back to the provider for the provider's accountability and responsibility, and we'll talk about that. For those of you from the medical side, you had 8 to 10 rules that you were responsible to be compliant for, which made up about half of a page, and now it's gone to 54 pages. So you may ask, how does that reduce costs? Well, what it does is really provide consistency across all of our provider groups and looking at the health and safety. And as you see, although it is extended licensing rules that we put in place, it gives a lot of the ability and the authority back to you all to establish your own policies and procedures, with a few exceptions that we've determined are health and safety risks, and we want to be able to make sure that you're in compliance with those. Streamlining the regulations is making sure that it's consistent across the board. so that when one surveyor comes in to survey you and the next surveyor follows you, that we're fairly consistent in what our expectations are and what's happening, and that you know as you move throughout the community what your partners and your colleagues who are providing the same services are expected to do. And then, of course, we wanted to facilitate that whole integration that we've already talked about. And as I've said, we focused on health and safety, looking at consistency, streamlining, and integrating those services. And one of the things on the last bullet on that slide that I kind of slipped through was our 5-year reviews. One of the requirements under our statutes is that all of our rules are reviewed every 5 years. So we take that information, and that 5-year review is based upon information that comes back to us from you as providers. It is input from the surveyors when they're out in the field surveying. It's input on our rules to determine, is there really a health and safety reason to have that rule? Because keep in mind, the focus of our rules is on health and safety. So those 5-year review comments were considered when we developed this review package. And this describes for you really the integration plan. And what it does for the outpatient treatment centers is it gives you a menu of services. And we'll walk through that when we look at the different sections within Article 10. So that you can provide not only solely behavioral health services, but you can provide physical medicine services as you choose to provide, as well as physical medicine facilities can provide behavioral health services, where before you had to go in and apply for 2 applications, one for behavioral health, one for licensing, and it had to be all separate and distinct. How many of you had to go through and remodel if you were providing both places? It had to be separate and distinct, and you won't have to do that now. So that was a big decrease in the monetary costs for the providers. These rules were submitted to the Secretary of State on June 28th and were to be implemented July 1. Well, submitting on June 28th and implementing on July 1 for you to all be in compliance was probably not very reasonable. So our director went and asked if we could have a postponed transition period of time, which means now that we were approved to implement on October 1. So since June 28th, the rules have been posted on the website, and you've had ability to look at those. They are identified on the website as unofficial rules, but those are really the official rules that we'll be implementing. The reason they're called unofficial is because they can't be official until they're identified by the Secretary of State. And the official copy has a lot of lines through it and revisions and deletions that you didn't really want to look at, which wouldn't be very usable to you. So please remember that the unofficial copy is the official copy. You do need to start following these rules as of October 1st. When we come out and survey, we will be surveying on the new rules. So want to make sure that you're in compliance. One of the things that we will be doing is to really look at how you're applying those rules, making sure that you understand those rules during the survey process, and providing a lot of technical assistance. So we're going to be providing a lot of technical assistance in helping you understand the rules. If we do fall into a health and safety risk, then we will probably have to do a citation. But our hope is that we're going to have to do enough of these education programs that you're going to understand, and the health and safety risks within your organization are going to be very minimal, and that we're going to be out providing mostly technical assistance as we survey. So expect that as we move forward. What you're going to find is a little more flexibility in the rules as it relates to policies and procedures. Not in the number of policies and procedures that are expected, because the number of policies and procedures are pretty high when you go through it, and we'll go through that today. But flexibility in what you determine as to what those policies and procedures say. And we're also going to be looking at flexibility in staffing. There are some parameters that we have to put in place because of statute and the law that's in place for that. But there is a lot of availability for you to be flexible in what you determine as your staffing needs are, and your training. A lot of training components when we go through the personnel aspect of this component of the rules. This is what you're going to see when you go on the website. This is the website. You should have all picked up a card that has the website on the card so that you can have that, go on, look at those rules. This will also be a key resource site for you as we move forward, because we'll have frequently asked questions. We're gathering all the questions that we gathered today in previous presentations as well. We'll do a frequently asked question format that'll be put on the website for you to look at. There'll also be some crosswalks on there. There'll be any updates that we have on the rules that'll be included into there, and then you'll be able to see these presentations. Which, as I talk about these presentations, we're going to ask you to hold all your questions. Take a note, write a question down, because we are taping the presentation today to go on the website. So you all get to be on our website. So you chose the right session to come to. This is an example of the crosswalk that you'll see on the website. We won't go through it in detail, but you'll see how that's related with all of the provider groups on one side, and then how that relates to the integration. And again, the website. And then, okay, for Article 10, and that's what we're going to primarily focus on today, that's the outpatient treatment centers. It's Title 9, Chapter 10, Article 10. And when we look at that, we're going to look at the rule content. We're going to go through definitions and where you find definitions, some of the additions that you're going to be experiencing that you're not used to having in rules, some interpretations, and then we're going to look at the article numbers have changed. So if you're used to looking at Article 1 for the 115 rules for the outpatient treatment centers, don't go to Article 1 anymore for your rules for outpatient treatment centers. You're going to go to Article 1 for other reasons, but not for your rules. You're going to go to Article 10. So keep that in mind. And just to give you additional background, you know, the rules are developed from statutes, and statutes are determined by your state legislatures, the people who we vote into office. Those are who determine what is going to become a statute, which the statute is the law. So when you look at a rule, it is developed from the law, and when you're not in compliance with one of those rules, you really are in violation of the law. And that's why it really is taken very seriously, and we have to continue to monitor, because we don't want anyone to be in trouble to be in a violation of a law. Now we're going to transition here over into a Word document here. And I'm going to try this a different way than what we did yesterday. And how many of you here were yesterday? There was some people here yesterday. The scrolling, we got some feedback, was kind of dizzy for people. So we're going to try to flip pages. It's a little bit smaller, so I hope that you can see all of this as we move forward. If not, we'll go to a different methodology. And I have to sit down, I'm sorry, because I have to flip the pages here. So provider responsibility. When we talk about provider responsibility, what is your responsibility from this point forward? And we're going to highlight the rules. We're not going to go through every word within this rule package. So we're going to highlight elements of this and review it. But it's your responsibility to go back and review all of the rules and make sure that you understand all of these rules and that you're able to demonstrate compliance. So when somebody comes in to validate your compliance to those rules, you should already know what the rules are and how you're demonstrating compliance to those rules. In your handouts today, we gave you a copy of the rules. So those are the rules that you'll be applying. And we also gave you an Excel spreadsheet that has all of the rules listed out for you. And it's kind of, we developed that just as a checklist for you to go through and then just kind of monitor, you know, are you in compliance? Are you not in compliance? And any comments that you might want to make. Perhaps it's a reference to a policy and procedure manual, or perhaps it's you know, a comment that you know that this person knows where information is, or your personnel files are located somewhere, so that it's a tool for you to use as you evaluate what services you're providing. It's not a mandatory tool to use. It's something that we just are providing to you as a source document. This is Article 1. Now, Article 1 is the general rules. So Article 1 applies to every provider group. So when you look at the rules, all I've given you is Article 10 today, but go in on the website, pull out the general rules so that you've got those. This is all the sections that are included in that article. And when you look at that, it has definitions. Most of the primary definitions that explain each of the individual words that are defined in the rules are in Article 1. There are a few in Article 10, but most of them are in Article 1, and you'll see that as we go through the presentation. I've referenced back to some of those. Then it's got your application requirements, your licensing exceptions, how to go through all the licensing process, your renewal process, and some of the new areas that are identified in Article 1 that have not been in Article 1 before relate to the enforcement actions, tuberculosis screening, and the behavioral health paraprofessionals and behavioral health technicians. So those of you who are providing behavioral health services, you're going to want to use Article 1 as a key source document for you. And then Section 115 in Article 1 relates to long-term care, which is the Nutritional and Feeding Assistance Training Program, if any of you have long-term care facilities associated with your organizations. Then we have counseling facilities and collaborative health care institutions. All have been added in Article 1. So if you're associated with any of those areas, you're going to want to look at Article 1 as you move forward. As I mentioned with definitions, these are the sources that you're going to want to go to look at definitions. You're going to want to look at Article 1, which we just talked about, has the majority of the definitions. I believe there's almost 200 definitions identified in Article 1. And then instead of Article 2 there, it should say Article 10. So you're going to want to use Article 10, so the definitions that are in there, and your Arizona Revised Statutes. If you look at Statute 36-400, that also has some definitions in. The definitions that are in statute are not repeated in the rules, because remember, the statutes are the law, and so therefore that becomes the foundation of all definitions, and then it's moved over into the articles, and the rules have further definitions that are assistive for clarification. Now this is what we're going to talk about with Article 10. So this is Title 9, Chapter 10, Article 10, and this is the outpatient treatment centers. And what I've highlighted here for you are in red are all of the sections that you must be in compliance with unrelated to the services that you're providing. So when we look at the sections, you're looking at from 1001 down to 1010, and we'll cover all of those sections today that you'll need to be in compliance with. And then you're going to be in compliance with 1028, 1029, and 1030. So those are all sections that you're going to need to be in compliance with. Then this is the menu that you're going to select from as to what services you're providing. So you'll select from 11 through, I believe it's 27. You're going to select what services you're providing within your organization. So that's what we consider our menu of services. And we'll go through each of those sections as we have represented today here, depending on who is doing what services. So, and I'm going to stop just one moment here and ask if some of the surveyors will come up here so that you can go back there and sit where you can see the slide presentation. Is everybody else, can you all see okay? Because there is room back in the back there if you want. Maybe a couple more surveyors can come up here so they can come back there and see the presentation. I want to make sure. Let's see. Can we have two more? Yeah.
Can I ask a question when you're orchestrating?
I'm sorry.
No. Other than obviously I can go into definitions and find the definition of governing authority, but can you address what governing authority means as far as the clinics, does it mean just who owns it? Does it mean, what is the best definition for a governing authority?
The governing authority is really who owns, who's accountable and responsible for the operations of the facility.
Okay.
Yeah. Thank you all for readjusting. I appreciate that. Does that work for you? Can you all see now? Okay, good. All right, so we're going to go into supplemental applications as it relates. Now, this is the first section, which is 10.002, and it's supplemental application requirements. What that means is these are additional application requirements to what is required in Article 1. Okay, so your application requirements for initial and renewals are identified in Article 1, so this is additional information for that. And what it talks about is the governing authority applying for an initial application will submit the initial application form, and you'll include the days and hours of clinical operation, and if different from the days and hours of clinical operation, the days and hours of administrative operation. So some of you may have your clinical hours Monday, Tuesday, Thursday, Friday, and Wednesdays are administrative hours. So you would need to submit that on your application. So make sure that if you have routine administrative hours that are different from your clinical hours, you want to include that in your application.
Is that just on the form, or do you need a letter?
On the form.
Like just down below, just put,
Yeah.
identify it?
Yeah.
Okay. Will that form eventually
What,
change?
can we hold the questions?
Oh, sorry. Sure.
Okay. All right. Then on number 2 is the request to provide one or more of the following services, and this is your menu of services. So this gives you the listing of services, and I flip through here. You got behavioral health services and all your behavioral health services, and then it goes into your diagnostic imaging, clinical lab, dialysis services, emergency services, pain management, and then you've got your sleep disorder, urgent care, and your counseling services related to that. So that's what you're going to be doing in addition to Article 1. So you're going to have your hours of operation, both clinical and administrative, and then you're going to define what your scope of services are and those services that you're going to be licensed for. So that's the supplemental application section, which is 1002. Now we go to 1003, which is administration. And this one talks about the single group licensing as it relates to facilities that have outpatient treatment centers, single group licensed under a hospital. Do any of you have single group license? We'll skip over this if you don't. The one thing I will mention to you that we haven't been able to do in the past under single group licensing is that you can now have behavioral health services under a hospital's operational services, where before we could not. So if a hospital opened an outpatient treatment center clinic that was providing behavioral health services along with maybe physical medicine services, that could now be a single group licensed entity under the hospital's license. So since we don't have any of those, we'll just skip through that. Then B, it talks about the governing authority, and keep in mind, as all of the lead-in statements give the accountability of who's accountable. So in this first section, it's going to say the governing authority is accountable. So it is important for you to know who your governing authority is and what they are accountable for. And so a governing authority shall consist of one or more individuals that's accountable for the organization and establish in writing the outpatient center's scope of services and qualifications for the administrator. In some of our rules previously, we defined the qualifications of an administrator. This is giving you the latitude to decide what are the qualifications of an administrator or your governing authority to decide what are the qualifications of administrator to provide the directions that are identified in the rules for that individual to follow. And then you designate an administrator in writing who has the qualifications that are defined by the governing authority and adopt a quality management program. Keep in mind that your quality management program must be adopted by the governing authority. So it's not a document that's just created and then sits on the shelf. It's created and adopted by your governing authority, and then the governing authority delegates you to implement that program. And then the governing authority has accountability to review and evaluate that, and we'll talk about that a little bit later when we talk about quality management. The governing authority also has to evaluate the effectiveness of the quality management program every 12 months and designate in writing the acting administrator who has the qualifications that they've established, and the administrator, if the administrator is expected not to be present on an outpatient treatment center's premises for more than 30 calendar days, or is not present on the outpatient treatment center's premises for more than 30 calendar days. They must designate someone in writing that's going to act in that stead. And this rule is important because of what we have found as we go through and look at some of our facilities. We have administrators that live out of state and never visit the facility. And we found that those facilities struggle with compliance because the administrator is not on site and understand what you all do on a day-to-day environment and maintaining those services. So this is a health and safety requirement that we put in. And then, except as provided in subsection BC, notify the department according to ARS 36425I, which is the Arizona revised statutes. And we've put that in here, and I know it's small for you to read. And I have integrated some statutes into this presentation so that you understand that not only looking at the rules, the Arizona Administrative Code, but you also need to have source review of the statutes. Because whenever it references a statute, it is understood that you will be in compliance with that statute. Keep in mind, the statutes are the law, so you don't ignore them. So in this case, the statute does state that you will notify the department whenever there is a change in your administrator or your applications would change as it relates to your locations. So that's that statute. Then the administrator is directly accountable to the governing authority. So the governing authority is the ultimate accountable person. They delegate an administrator based upon the job qualifications that they've set, and then the administrator is accountable to the governing authority. And then, except as provided in subsection B7, designates in writing an individual who is available and accountable for the operations of the outpatient treatment center when the administrator is not available. So it may be that the administrator is not available in less than the 30 days, because keep in mind with the 30-day requirement, but if it's less than 30 days, who is there and available who can respond to the administrator's needs and what the administrator is accountable for when that administrator is not available. Policies and procedures are a big part of the administrator's responsibility and ultimately, again, the governing authority. And when we talk about those in the rules, they're outlined in 3 different areas. There's administrative policies and procedures, there's clinical policies and procedures, which are your services, and then there's a section that talks about the implementation of policies and procedures, or the responsibility for ensuring that those policies and procedures are completed appropriately. So when we talk about the policies and procedures, first of all, there's 3 elements to policies and procedures. They must be established, documented, and implemented. And the third component of that is key. So you can have established policies and procedures. They can be documented either electronically or in a paper process, but are they implementable? You know, do your staff understand them? Do they know them? And can they implement them? So when you're evaluating whether your policies and procedures are current, effective, and ongoing, you may need to do some observations. You may need to do some checks and balances to see, are these really policies and procedures that we can implement or are implementing? Because remember, with the latitude here, we're going to allow you to develop your own policies and procedures with just a very few parameters surrounding that. So we're going to hold you accountable to your policies and procedures. So whatever you say in your policies and procedures are what you're establishing as your basic fundamental performance standards based upon evidence-based or best practice, however you determine that, or standards of care. And so we're going to hold you accountable to all of those. So in addition to that, as I talked about the established, documented, and implemented, you're going to have your job descriptions. You're going to document your job descriptions, and those job descriptions are going to describe the duties and qualifications of your skills, knowledge of your staff, and the education and experience of your staff. Your personnel members are substitute for employees, so it's all members who participate in the center. And then you're going to do orientation and in-service. So you're going to have your job descriptions, you're going to have orientation, you're going to have in-service surrounding that. Then you're also going to cover smoking and the use of tobacco products, how your personnel members respond to sudden, intense, out-of-control behavior of a client that might be coming in or a patient who might come into the center. And then your policies and procedures are going to be reviewed at least every 2 years. So previously in many of our rule sets it said 3 years, and now it's 2 years. And as healthcare is changing and evolving, this was another important aspect when we looked at it, that really things don't stay stable for 3 years anymore. Practices change, technology changes, so we are asking that there be a 2-year review, and that they're available to all personnel members and employees. So these 2 slides just give you kind of, I wanted to pull together the volume of policies and procedures that are required. And those are your job description, CPR training, first aid training, patient rights, healthcare directives, medical records, quality management, contract services, general consent and informed consent policies and procedures, medication obtaining, storage, and disposal, general and informed consent, infection control, telemedicine, environmental services, complaint process, smoking and tobacco product use, and response to the behavior. So those are your administrative policies and procedures that you need to have in line. When we come into the department, or if for whatever reason the department's entering your facilities, all of your documents need to be available within 2 hours. So when we look at that, you know, it used to be 4 hours across in most of our rules. It's now decreased to 2 hours. And when we looked at that, we felt that 2 hours was reasonable with electronic documentation, with electronic access to documents, that we felt that this was reasonable to be able to attain. When you see the rules and when you read the rules, you're going to see that it doesn't require you to have documents on site. It says that your documents will be maintained. So we know that there are some facilities that are quite small, and that to maintain all the documents that we're going to ask for or have available to us might be burdensome for some providers. So we made a decision it would be maintained, but keep in mind they need to be available within 2 hours. So as we go through this, think about, you know, if you're going to store documents at a corporate office or off-site in a storage center, what are your requirements? What are your agreements to be able to access those records? And then the following areas need to be conspicuously posted. Your current license. A copy of the original license should be available and posted wherever the general public who comes into your center will be able to view it and see it. So make sure that that is posted. You will also have to post the name and address, telephone number of the department. And then as you look at that, you also have to have one of the following: a schedule of rates, which is according to the Arizona Revised Statute 36436, or a notice that the schedule of rates required, ARS 3643601, is available for review upon request. So I too have pulled over the statutes, again, not to read these statutes, but just to let you know that they do exist and that there is content within those statutes that supports the rule. So again, the statute is the law as we move forward, and that's what's required by the law. Again, posting, you're going to need a list of the patient rights. And we'll talk about patient rights because there is a section on patient rights, but you're going to need to have that posted, and a map for evacuating the facility. And again, the posting of the rights and the inspections and the posting of that is also by statute. Patient follow-up instructions. You will need to provide your patients with follow-up instructions after the visit, and those can be provided orally or written. And if they are provided orally, that it does need to be documented in the medical record, or if they're provided written, you can just attach a copy into the medical record. So make sure that you are documenting all follow-up instructions and recording that into the medical record. Then also, if abuse, neglect, or exploitation of a patient is suspected as those individuals come into your center, you're going to want to reference over to statute. And again, this is ARS 46454 and ARS 133620, and that is spelled out in your rules. The 46454 results to the adult reporting requirements of a vulnerable adult, and that you need to notify Adult Protective Services or the local police agency in order to come and do an investigation or make a decision as to whether they're going to investigate or not based upon the information you've provided to them. And 133620 relates to children. And so if you are providing services to children and suspect abuse, and again, this is the law, it is required by anyone providing medical services or behavioral health services to report anything that relates to abuse, neglect, or exploitation. Then if abuse, neglect, or exploitation occurs on your licensed premise during the services that is being provided to an individual, then you have some responsibility under these rules in addition to following the statutes and the statutory requirements. You must take immediate action to stop the alleged or suspected abuse or neglect and exploitation, whatever is appropriate to stop that action. Immediately report the alleged or suspected abuse according to the statute, and document the action in the subsection and maintain the documentation for 12 months after the date of the report. Investigate the suspected or alleged abuse, neglect, or exploitation, and develop a written report of the investigation within 48 hours after the report required in section F2. That includes dates and times and description of any injury, names of witnesses or alleged suspected abuse, and actions taken by the administrator. And then you need to submit that investigation report within 10 working days to the department and maintain a copy of that investigation report for 12 months after the date of the report. We go into the next section, which is quality management, and that's section 1004. And this is new for most of our outpatient treatment centers. Many of you have a quality management program in place. We recognize that because you've just determined that that's a best practice for you all. However, there are some outpatient treatment centers that had not integrated a quality management processes within their organizations. So we have given some basic foundation for what a quality management program might be and what that would include. So a quality management program is a plan that is established, documented, and implemented for an ongoing management program that at a minimum includes, and at a minimum it will include the method to identify, document, and evaluate incidents, a method to collect data and evaluate the services provided to patients, and a method to evaluate that data through your own analysis process, and a method to make changes or take action as a result of the activities that you're doing through identification, collection, and evaluation, and the frequency of submitting a documented report in subsection 2. So your plan will require all of those elements to be identified. And then also included in your plan that you'll have a documented report that's submitted to the governing authority that includes an identification of each concern about the delivery of services, a change made or action taken as a result, and then the report that's submitted to the governing authority will be maintained for 12 months after the date of the report is submitted to the governing authority. So pretty basic parameters. It's just an outline for your quality plan, and this is what we would require as a minimum requirement. This just is a summary of the quality report that we talked about. Section 10, at the end, please. Section 10.05, contracted services. And this is a small section, but please remember that any contracted services that you have that relate to patient care services, that you have a documented list of those contracted services, and you maintain that documented list so that it's available, that identifies the description of each of those services. Personnel is section 10.006. And this is where we talk about the qualifications of your personnel. So your qualifications, skills, and knowledge required in each of the type of personnel. And keep in mind, we talked about earlier under administration that job descriptions needed to be defined. So your job descriptions are going to go hand in hand with this section. And when we talk about a personnel member, I put in a reference to the definition. And the definition of that is a medical, excluding a medical staff member, an individual providing physical health services or behavioral health services to a patient. So it's anyone who's providing services. And that the qualifications, skills, and knowledge are based on the type of physical health services or behavioral health services that are provided, and that they are identified according to the job description that's been established, and the acuity of the patients receiving the physical health services or behavioral health services are taken into consideration when you're developing those qualifications. There is not a rule that requires a specific acuity system, but you need to look at the acuity of your individual clients or patients that are coming into your center and make a decision as to what the scope of your qualifications, education, experience of your personnel needs to be in order to meet the needs of those patients. And it may vary from one facility to another based upon that patient population. Then you also need to include the specific skills and knowledge necessary for the personnel member to provide those expected services that you've identified. The type and duration of education, so you have experience and you have education, and then the duration of that experience. Then it lets you determine how you verify. You do need to verify that experience and that educational components, but it is up to you to determine how that verification is done, and that verification needs to be documented. And that needs to occur before the personnel member provides services within your facility and according to your policies and procedures. And then it requires that personnel members are present on the licensed premise whenever there are patients there, and they have the ability to meet the patient's needs to ensure the health and safety. And that the personnel member only provides those services that they're qualified to provide. And then a plan is developed and documented and implemented to provide orientation. So you're going to have an orientation plan, and that you complete the orientation before providing services to patients. and the orientation plan is documented by the name, date, and subject or topics. And a plan is developed and implemented for in-service education. So you have plans for orientation, you have plans for in-service. And then on the in-service documentation, you have the personnel name, date, and subject or topics. And then you're in compliance with the requirements for behavioral health technicians and behavioral health paraprofessionals. And this is an area that refers you back to Article 1. So when you look at this, it refers you back to Title IX, Chapter 10, Section 114, and that's where it defines a behavioral health technician and a paraprofessional. And I'm going to let Brian talk to that a little bit later when we go through behavioral health. And then you have a record of your personnel member, employee, volunteer, and student is maintained. Again, maintained, and includes the name, date of birth, home address, contact telephone number, your starting date, and your end date if your end date is appropriate to include. The individual's qualifications, including the skills and knowledge, the individual's education and experience, the completed orientation, the license or certification if it's appropriate for that individual, and then the behavioral health technician clinical oversight. And I have included here for you, again, R910, which is Title IX, Chapter 10, 114, which is in Article 1, that goes through the behavioral health professionals and behavioral health technicians as it talks about clinical oversight and supervision. And we'll talk about that later when we go through behavioral health. Then you also have the individual's compliance with fingerprinting requirements if it is required for your facility. And again, it references back to statute 36-425-03 for fingerprinting requirements. Cardiopulmonary resuscitation training, if the individual is required to have cardiopulmonary resuscitation training. Again, that goes back to your policies and procedures. And the record is maintained while the individual provides services for at least 2 years after the last date the individual provided services. And if the ending date of employment was 12 months or more from the date that the department would ask for that personnel record, you do have 72 hours to produce that record. So keep in mind all other records are produced within 2 hours, but this gives an exception to personnel records if you have individuals who are no longer in service at your facility and have been gone for 12 or more months. Section 1007, transport and transfer. And there are definitions for transport and transfer, and those go back to Article 1. And I have put the definitions here, and for those of you in the back, I'm going to read that. Sending a patient to another healthcare institution for outpatient services with the intent of returning the patient to the sending healthcare institution, or returning a patient to a sending licensed healthcare institution after the patient received outpatient services. So an example of that would be if you're providing general physical medicine and you're a general clinic and you decide that an individual needs an x-ray and you want them to go to another licensed healthcare facility that provides x-ray services with the intent that that individual is going to come back to your facility for continued follow-up, then that's considered a transport. So you're transporting that individual to the x-ray with the intent that that person's coming back for continued care on that same visit. If you're giving them a prescription for x-ray and then you're going to get the reports and then call them the result, that would not be a transport. It's if they're coming back to your facility. And these rules would apply for a transport except in an emergency, that a member of your clinic coordinates the transport of, and the services provided to the patient. An evaluation of the patient is conducted before and after the transport. Medical records are provided, and you explain the risks and benefits of the transport to the patient. And then documentation in the patient's medical record includes communication with an individual at the receiving healthcare institution, the date and time of the transport, the mode of transportation, and the personnel member accompanying the patient. So that's what you would do in transport. And then in transfer, again, the definition is found in Title IX, Chapter 10, Article 1, and it happens to be Definition 190. And that's discharging a patient and sending a patient to another licensed healthcare institution as an inpatient or resident without intending that the patient be returned to the sending healthcare facility. So if you're a behavioral health facility and you're providing maybe crisis evaluation and stabilization and you determine that they're transported to an inpatient facility, then that would be a transfer. So then in this case, the transfer requirements would be that, again, coordination of the transfer and the services, the evaluation of the patients conducted before the transfer, medical records including the orders that are in effect at the time of the transfer, and any other medical records that would be appropriate. You're explaining the risks and benefits of the transfer, and you're documenting in the patient's medical record includes the communication date, time, mode of transfer, and the personnel member accompanying that individual if it's appropriate. Sometimes you won't have an individual from your clinic accompanying, but you may have an ambulance company. You're going to want to document that, or a transport company service. And again, if you have any questions, write them down and we'll cover them. Section 1008, which is patient rights. Again, this is new for most of the outpatient treatment centers. And the requirements in this section will be conspicuously posted on the premise. All of your patient rights will be conspicuously posted. And then at the time of admission, a patient or a patient's representative receives a written copy of the requirements in subsection B, which will be your patient rights, and the patient rights in subsection C. There are policies and procedures that include how and when a patient or the patient's representative is informed, where the patient's rights are posted. So you're going to have, again, policies and procedures of how the patients are informed and where they're posted. And the administrator will ensure that a patient is treated with dignity, respect, and consideration. And a patient's not subjected to the listing that's here, which is abuse, neglect, exploitation, coercion, manipulation, sexual abuse, sexual assault, seclusion. Restraint is not necessary to prevent, if not necessary to prevent imminent harm to self or others. Retaliation for submitting a complaint. Misappropriation of personal or private property. And then a patient or a patient's representative, except in emergency, either consents or refuses treatment, may refuse or withdraw consent, and except in an emergency is informed of alternatives to proposed psychotropic medication or surgical procedures. And this would require an informed consent in either of those cases. Excuse me. Psychotropic medication is defined in Article 1, and it's definition 152. And I believe Brian will go through that a little bit in his presentation as it relates to that. But keep in mind, even if you're not providing behavioral health services and you prescribe or administer a patient a psychotropic medication, that it does require the patient's consent. It's not just related to behavioral health services. The patient is informed of the healthcare directives, the outpatient treatment center's policy on healthcare directives, the complaint process, and consents to photographs of the patient are obtained before the patient's photographed, except if you're using those photographs for patient identification. And if you're using them for patient identification to attach to a medical record, you can go ahead and do that without consent. It's always nice to tell the patient that's what you're doing, but you can do that. Except as otherwise permitted by law, provides written consent or release of the patient's medical record and financial records, and that they won't be discriminated against based upon race, national origin, religion, gender, sexual orientation, age, disability, marital status, or diagnosis. Then they need to receive treatment that supports and respects the patient's individuality, choices, strengths, and abilities, and to receive privacy in treatment and care for personal needs. And to review upon request the patient's medical record, and that's according to statute, which is ARS 12-2293, 2294, and 2294.01. And I have included those, and I included these not to review them today, but just so you can see the content of these statutes. And the first 2293 is the release of the medical records to patients and healthcare decision makers. And then the 2294 is the release of medical records and payment records to third-party payers. And the 2401 is the release to third parties pursuant to a subpoena. So there's 3 different sections in there that you want to be aware of as it relates to medical records. Patient has a right to receive a referral to another healthcare institution if the outpatient treatment center is unable to provide that service that the patient's required, and participate or have the patient's representative participate in the development of decisions concerning treatment, and to participate or refuse to participate in research or experimental treatment, and to receive assistance from a family member representative. So this is a long list of patient rights. So when you go back and you look at your patient rights, or you're developing patient rights if you don't already have them, you want to use this list to make sure that you're all inclusive. It does not mean that you can't add other rights to your list, but you do have to have a minimum requirement of these. Medical records. We'll go through a medical records and talk about what's required in a medical record. And that medical record is established again according to statute, which is the Arizona Revised Statute, Title 12, Chapter 13, Article 7.1. And that an entry in the medical record is recorded only by a personnel member authorized by policies and procedures to make an entry. It's dated, legible, and authenticated and not changed to be illegible in any way. And an order is dated when the order is entered in the patient's medical record, so no matter who enters it, whoever enters that should date the order. It needs to be authenticated by a medical practitioner or behavioral health professional according to your policies and procedures. When an order is a verbal order or a telephone order, verbal order includes telephone orders, it must be authenticated by the medical practitioner or behavioral health professional issuing the order. A little bit different than some of your policies and procedures may state that an alternative medical practitioner can sign somebody else's verbal or telephone order. The rule here states that it has to be done by the person who's issuing the order. Then if a rubbered stamp signature or electronic signature code is used, it's the responsibility of the individual who that's used for to keep that under control and managed. And the medical record is available to all personnel members who need to have it available according to your policies and procedures. And information in the patient's medical record is disclosed to an individual not authorized under Section A5 only with the written consent of the patient. And policies and procedures include a maximum time frame to retrieve the patient's medical record. And the patient's medical record is protected from loss, damage, or unauthorized use. And one of the examples that we had asked you to go back and look at your centers and see where are your medical records stored. And do you have medical records that are maintained out in an open area where the sprinkler system may go off and damage those records? or are they locked and secured so individuals who come into your center don't have access or can't read those records, excuse me, from that area? Then if the outpatient treatment center maintains their medical records electronically, that you're going to safeguard those records to prevent unauthorized access. The date and time of an entry in the patient's medical record is recorded by the computer's internal clock. So if you do have electronic records, make sure your date and timing is done by your internal clock. And then patient information, with the exception of an exception that occurs in the Arizona Administrative Code R96-10005, and this is the only reference that's outside of Title IX, Chapter 10. This is in Title IX, Chapter 6, and that relates to HIV testing. So, but other than that, you would have the patient's name and address, date of birth, the name and contact information of the patient's representative, diagnosis or reason for the treatment that they're receiving in the outpatient treatment center, documentation of general consent, and if applicable, the informed consent. And again, general consent and informed consent are defined in Article 1, so you'll be able to find that in Article 1. And then documentation of the medical history, orders, assessments, treatment plans, interval notes, progress notes, and interval notes are really documented by the professional, the medical professional, or the behavioral health professional, which is in addition to a medical history and physical. If you call it all progress notes, that's okay, just so you know that it is defined differently in the rules. But if you're calling both an interval note and progress notes the same, that is a technical issue that we would not cite you for. Documentation of an outpatient treatment center and services provided, and name of each individual providing treatment or diagnostic services. So when somebody provides the treatment, there should be an associated name to that as to who's providing that. Disposition of the patient upon discharge, any follow-up instructions, and we talked about that earlier. And then a discharge summary needs to be documented. And again, discharge summary definition is found in Article 1, and it means a documented brief review of services provided to a patient, current patient status, and reasons for the patient's discharge. So when you're looking at your policies and procedures and your medical staff protocols, does it include a discharge summary, and does it meet these minimum requirements? Your laboratory reports, radiology reports, any of your diagnostic sleep, diagnostic reports, any documentation of restraint or seclusion, and any consultation reports should all be included in your medical record. Medication that's been administered, the date, time, name, strength, dosage, and route of administration. And the medication administered for pain must have an assessment prior to and after administration of pain medication. And the same for a psychotropic medication. You have to have an assessment of the patient's behavior before and the effect of the medication. The identification, signature, and professional designation of the individual administering or observing self-administration. Any adverse reaction, and your pre-packed or sampled medication with the name, strength, dosage, amount, route of administration, and expiration date. We'll go through Section 1010, and then we'll take a little bit of a break. Section 1010 is medication services. Again, this will be required for everyone who's licensed as an outpatient treatment center. You'll have your policies and procedures, again, that include the process for providing information to a patient about medications that's been prescribed, the prescribed medication and anticipated results, the potential adverse reactions, potential side effects, and potential adverse reactions. procedures for preventing, responding to, and reporting a medication error, an adverse response, a medication overdose, and procedures to ensure that a patient's medication regime is reviewed by a medical practitioner and meets the patient's needs, procedures for documenting medication services, procedures for assisting a patient with obtaining medication, and procedures for providing medication administration or assistance in self-administration, and your medication services policies and procedures and implementation of those policies and procedures is reviewed through a quality management program. And you identify a medication administration error and adverse reactions included in that quality management program. Your policies and procedures are reviewed for medication administration and approved by your medical practitioner. Specify the individuals who can order medications and administer medications, and administered as prescribed. And a patient's refusal to take a prescribed medication is documented in the patient's medical record. And verbal orders for the medication services are taken by a nurse unless otherwise provided by law. A medication is administered to a patient, observing the patient while the patient removes the medication. Are any of you doing self-administration? Some of you are, so we'll go through that. Then you're going to verify that the medication is taken as ordered by the patient's medical practitioner by confirming that the patient is taking the medication that was stated on the medication container label. The dosage of the medication is the same as stated on the medication container label, and the medication is being taken by the patient at the time stated on the medication container, or observing the patient while the patient takes the medication. Policies and procedures for assistance in self-administration of medication are reviewed and approved by the medical practitioner or a registered nurse. Training for personnel member other than medical practitioner or registered nurse in self-administration of a medication is provided by the medical practitioner or registered nurse or an individual trained by the medical practitioner or registered nurse to do that. And so your training program includes a demonstration of personnel member skills and knowledge necessary to provide assistance, identification of medication errors and medication emergencies related to medication, and processes for notifying the appropriate entities when an emergency medical intervention is needed. And then a personnel member other than a medical practitioner or registered nurse completes the training in subsection C4 before a personnel member is allowed to assist in self-administration of medication. And assistance with self-administration medication provided to a patient is in compliance with an order and documented in the patient's medical record. Then you need to have a current drug reference available and a toxicology reference available. And then when a medication is stored at an outpatient treatment center, there's a separate room, closet, or self-contained unit used for medication storage that includes a lockable door. If the medication is stored in a room or closet, there is a locked cabinet that's used for medication storage. Then medication is stored according to the instructions on the medication container, maintaining appropriate temperature control. Policies and procedure established for receiving, storing, inventorying, tracking, dispensing, and discarding medications, including expired medication. Discarding or returning packaged and sampled medications to the manufacturer, and a medication recall and notification of patients who received a recalled medication. Storing, inventorying, and dispensing controlled substances. The administrator shall ensure that a personnel member immediately reports a medication error to the or a patient's adverse reaction to a medication to the medical practitioner. It says immediately. And the definition of immediately is without delay. Okay. Now, in your packet, you're going to have where we would move into the behavioral health services, behavioral health observation, and those components, and we're going to hold those to the end. But we'll take maybe a 10-minute break so you can stand up and stretch at this point in time. All right, let me ask you, is anybody here doing lab solely? Are you doing lab? So we're going to skip through the areas that we don't have a representative here to talk about. So we'll move on from lab. How about diagnostic imaging? Imaging is here, so we're going to talk through imaging. And in the diagnostic imaging requirements are under section 1017. And it requires an administrator of an outpatient treatment center that provides diagnostic imaging services will designate an individual to provide direction to diagnostic imaging services who is a radiology technologist certified, and that the certification is under Title 32, who has at least 12 months experience in an outpatient treatment center. Now, I will tell you the 12 months experience in an outpatient treatment center has come up in other presentations, and can it be 12 months experience in other environments? And we will look at that, but for right now, this is what the rule is, and that's what will be in effect come October 1. Physician or radiologist. And ensure that diagnostic imaging services are provided in compliance with the statute. Again, this has a lot of statute references to it, so you need to go back and look at the statute. And a copy of a certificate documenting compliance with subsection 2A, which is the compliance to the statute, is provided to the department for review upon the department's request. And the diagnostic imaging services are provided to a patient according to an order, and that order includes the patient's name of the ordering individual, the diagnostic imaging procedure ordered, and the reason for the diagnostic imaging procedure. Those are pretty basic foundation functions that are required, but are now included in the rule. A physician or radiologist interprets the diagnostic imaging, and a diagnostic imaging patient report is completed that includes the name of the patient, date, and the physician or radiologist's interpretation of the diagnostic image. Anyone here doing dialysis? So we'll skip through dialysis here. Which you'll be able to move through several pages. So you can see why it's a long document, because some of it does not relate to you if you're providing one modality of service. We'll go to emergency room services. Anyone providing emergency room services? This is a freestanding emergency department. No? We'll skip through that. How about pain management? Pain management, and that's under section 1021. And so again, the administrator is the accountable person, and the administrator will ensure that pain management services are provided under the direction of a physician. And it does specify physician. You'll notice in some of the rules it'll say medical practitioner, and the medical practitioner gives you the latitude of a physician, a nurse practitioner, or a physician assistant. Here it is physician. And a personnel member certified in cardiopulmonary resuscitation is available on the outpatient treatment center's premise. Sorry about that. Don't know exactly what happened there. And if a controlled substance is used to provide pain management, the medical practitioner discussed the risks and benefits, and the following information is included in the medical record: the patient's history or alcohol substance abuse, the documentation of the discussion related to the substance abuse, and the benefits of the controlled substance, and the nature and intensity of the individual's pain, and the objectives used to determine whether the patient is being successfully treated. And if an injection or a nerve block is used to provide pain management services, before the injection or the nerve block is initially used on a patient, an evaluation of the patient is performed by a physician or a nurse anesthetist. An injection or nerve block is administered by a physician or a nurse anesthetist. And the following information is included in the patient's medical record. An evaluation of the patient is required, and a record of the administration of the injection or nerve block and any resuscitative measures that were taken. Physical health services is a general category, and this fits for your general clinics. So if you are a general clinic providing services, you'll see that you will need to be in compliance with all of the rules that are identified in red when we went through that. And then in addition to that, if you have medical services that are provided, that it must be under the direction of a physician or a registered nurse practitioner, and that the nursing services provided under the treatment center will be under the direction of a registered nurse. So you have medical services under the direction of a physician or nurse practitioner, nursing services under the direction of a physician, and then you must have personnel members certified in cardiopulmonary resuscitation. So those are the 3 additional requirements if you're in a clinic to all of the sections 1 through 10, and then the last 3 sections that we'll talk about, 28, 29, and 30. How about rehab services? We can skip through that. Respite services? Okay. So we have section 1025. And included in that are the administrator, again, is the accountable person, as delegated by the governing authority, to ensure that respite services are not provided in a personnel member's residence unless the personnel member residence is licensed as a behavioral health supportive home. Respite services are provided in a patient's residence or up to 10 continuous hours in 24-hour time period in the community. And if respite services are provided in the community, a patient's need for food, water, rest, and personal hygiene are met. So again, small set of rules, but remember you do need to be in compliance with all of the other articles from Article 10001 through 1010, and then the last 3, 10, 28, 29, and 30. Sleep disorder. Urgent care. Okay, urgent care services is 1027. And this is freestanding urgent care services. And then again, the administrator is accountable and responsible and will ensure that there are policies and procedures established and documented and implemented that cover basic life support, training, and pediatric life support training. Method and content of the training, qualifications of individuals who are providing the training. So if you're contracting for an individual to provide training in your urgent care services, make sure that you know the qualifications of that individual, or if you're doing it internally, what those qualifications are that are established. A medical practitioner is on the premises during the hours of clinical observation to provide medical services, nursing services, and health-related services. And if a physician is not on the premises during the hours of operation, a notice is posted, conspicuously posted, in the waiting room according to the statute. So if you have an urgent care center that the physician is not present within the center, then you need to post so that the public can conspicuously see that a physician is not present. If a patient's death occurs at the outpatient treatment center, a written report is submitted to the department according to statutory requirements. And a medical practitioner completes basic life support training and pediatric life support training before providing the medical services and at least every 2 years after the initial date of employment. And then except as provided in the subsection 5, a personnel member completes basic adult and pediatric cardiopulmonary resuscitation. So this includes both if you're doing urgent care, adult and pediatric, before providing medical services, and again, at least every 2 years. And in R910-1006A9, which refers back into Article 10-1006, the medical practitioner's record includes documentation of completion of the basic life support training and pediatric life support training. Okay? Now we're going into another section that is covered for all of you, and that's R910-1028, which is infection control. So this applies to all licensed outpatient treatment centers. And an infection control program is established under the direction of an individual qualified according to the outpatient treatment center's policies and procedures. So you must have an individual who, according to your policies and procedures, is considered the infection control responsible person for implementation of your policies and procedures. That person will identify and document infections, or a method to identify and document infections, analyze analysis of the types, causes, and spread of infections, the development of corrective measures to minimize or prevent infections, and documentation of infection control activities that include your collection, your analysis of all of those activities, your action taken, again, follows the quality management process, and reports of any communicable diseases to the appropriate agencies. And infection control documentation is made for at least 2 years. And the policies and procedures for reporting and control of communicable diseases and infestations, use of your personal protective equipment in addition to handling and disposing of biohazardous waste, your sterilization process and disinfection of your medical equipment, and collection and storage of cleaning and soiled linens. Just to step a moment back with the sterilization and disinfection, make sure that if you are sterilizing and disinfecting within your clinic areas that you're following the manufacturer's guidelines based upon what sterilization equipment that you have, and that the personnel within your clinics understand how to implement that process. We have had several deficiencies related to this, so they're not doing the quality controls and the testing accordingly. Cleaning an individual's hands when the individual's hands are visibly soiled. Then you want to train your personnel members in your infection control policies and practices, and work restrictions of personnel who have communicable diseases or infected skin lesions. Your biohazard medical waste is identified and disposed of accordingly, and there is statute for that. And your personnel members washes his or her hands with soap and water or uses hand disinfection product before and after each patient contact. And this does include physicians. And an administrator shall comply with contagious disease reporting requirements. And that again refers back to your statutory law. Emergency and safety standards is section 1029. Again, applies to everyone who has a outpatient treatment center licensed. And that's an administrator shall ensure that policies and procedures for providing emergency treatment are established and documented and implemented to protect the health and safety of patients, and includes, and this again is up to your governing authority, your administrator, and your clinical practitioners, a list of medications, supplies, and equipment required on the premises for emergency treatment, a system to ensure medications and supplies and equipment are available and have not been tampered with. So you'd have to have some type of secured system to protect that emergency equipment supplies. And then a requirement that a cart or container is available for emergency treatment that contains those medications, supplies, and equipment that's been identified in your policies and procedures. And a method to verify and document the contents of the cart or container available for emergency treatment. And the administrator shall ensure that emergency treatment is provided to a patient admitted to an outpatient surgical center according to the outpatient surgery center's policies and procedures. Again, it leaves it up to you to develop what level of emergency services you're going to be providing in your center. Then a disaster plan is developed, documented, and maintained in a location that is accessible to all personnel. Procedures for protecting the health and safety of patients and individuals are included into that disaster plan. Your assigned responsibilities for your personnel, instructions for evacuation, and arrangements to provide medical services, nursing services during a disaster implementation plan. And one of the things that I would like to mention to you here is many of you have disaster plans that relate to electrical outage, maybe water limitations, or perhaps indications where the water is not safe, your telephone outage, things like that. But I would ask you to look at natural disaster. Do you incorporate all of your natural disaster components that could occur? Do you have procedures in place and situations in place defined in your plan that talks about sheltering in place? You know, as we look at what's happened across the country, you know, if you look at the floods most recently in Colorado, if people were in clinics and now there's floods, they can't get home, you know, you would need to shelter in place and provide services to those individuals. So what would you do within your organization if you had to shelter in place for 12 hours, 24 hours, 36 hours in order to be able to support the medical needs as well as the individual personal needs of patients? So think about that as you look at your disaster plans. Your disaster plan is reviewed at least every 12 months, and an evacuation drill on each shift. So those of you who have more than one shift, you'll have to do an evacuation drill on each shift at least once every 12 months. Then you're going to take the disaster plan review or an evacuation drill, and you're going to look at the date and time of the evacuation drill, the name of each personnel member that was involved in that evacuation drill or disaster plan review, a critique of that evacuation drill or disaster plan, and if applicable, recommendations for improvement. So you're going to document that. You're going to evaluate what you've done, how have you done it, have you followed your policies and procedures, and what recommendations can you make to improve. And that documentation is required to be maintained for 12 months. The evacuation path must be posted conspicuously so that individuals know how to get out of your building. And then the following are tested and serviced at least every 12 months. That's your fire alarm system and your sprinkler system. And then a smoke detector is installed in each hallway of the outpatient treatment center that is maintained in an operable condition, is either battery operated or hardwired with battery backup and tested monthly, or a portable operable fire extinguisher is available in the outpatient treatment center and is mounted in a fire extinguisher cabinet or placed in wall brackets, and it's very specific here, so that the top handle of the fire extinguisher is not over 5 feet from the floor and the bottom of the fire extinguisher is at least 4 inches from the floor. So look at your centers and see if they're mounted. Most of you who have fire inspection occurring by the public agencies, you probably meet this requirement, but just go back and look at that. And if a disposable fire extinguisher is replaced disposable fire extinguisher is replaced when its indicator reaches the red zone. And if a rechargeable fire extinguisher is serviced at least every 12 months and has a tag attached to the fire extinguisher that specifies the date of the last servicing and the name of the servicing person. And then the administrator shall ensure that documentation of a test required in subsection D is maintained for at least 12 months, and that's the testing of your emergency support systems. Exit signs are illuminated, and they actually are illuminated, not that they just have the capability of being illuminated. Your corridors are 44 inches wide, And corridors and exits are kept clear of any obstructions. And again, that's important, so if you have to evacuate, can you get out? And a patient can exit through any exit during the hours of operation. Doesn't mean that you have to have every exit so that patients come and go through different doors, but just if you had an emergency condition, can patients get out all of your exits that you have within your entity? An extension cord is not used instead of a permanent electrical wiring. Electrical outlet and electrical switch has a cover plate that's in good repair. And a sign indicating that oxygen is used is placed at the entrance of the service area that you're providing services in or a room. Doesn't mean that you have to have an oxygen sign on every door within your facility. If you want to put one oxygen sign, oxygen is in use, that's conspicuously posted and that you follow through with that, that's okay. You don't need to make multiple signs to post them. However, if you have isolated areas where oxygen is stored and it's not conspicuous to the signage that the one sign that you've posted, then you may need multiple signs. Oxygen and medical gas containers are maintained and secured upright, stored in a room with a door, and in a building with sprinklers at least 5 feet away from any combustible, and if without sprinklers, at least 20 feet from any combustible. And the administrator will obtain a fire inspection conducted according to the local fire department or the state fire marshal. And depending on the local municipality that you're from, those fire inspections vary according to that local fire department. Make any repairs or corrections stated on the fire inspection report, and maintain documentation of the current fire inspection report. And you'll notice that in your application process it does require a fire inspection report. Section 1030, the physical plan, environmental services and equipment standards. The administrator shall ensure that an outpatient treatment center's premises are sufficient to provide the outpatient services in the scope of services. So what that means is that you have the appropriate physical space to provide services to individuals. Look at your capacity and the volume of individuals that come into your center, and do you have the appropriate space, or are you lining people up in a hallway that you should have 44 feet of clearance space to get out in case of an emergency. So look at your facilities, because that is what that means. Clean and disinfected according to outpatient treatment centers' policies and procedures that minimizes and controls illness and infections, and free from a condition or situation that may cause an individual to suffer a physical injury. And then if you are an outpatient treatment center that collect urine or stool specimens from a patient, that you must have at least one bathroom that contains the following list of items, which is the general requirements for a bathroom. And then a pest control program is implemented and documented. And your tobacco smoke-free environment's maintained. A refrigerator is used to store your medications. And equipment in the outpatient treatment center is sufficient for the outpatient treatment center's scope of services. Keeping in mind it says based upon your scope of services, so it's not telling you how much equipment, how much space you need. It's based upon your scope of services, so you have the latitude to be able to define that. And that you use equipment according to manufacturer's recommendations. And if applicable, tested and calibrated according to the manufacturer's recommendations, or if there's no manufacturer's recommendations, according to your policies and procedures. And then the documentation of that calibration and repair is maintained for 12 months. And there is an exception here for the outpatient treatment centers that are licensed before October 1 if you don't have a bathroom for exclusive use. If you're collecting urine specimens and stool specimens, it does allow you to use that common bathroom as long as you have policies and procedures that protect the health and safety of individuals. And that, again, was another monetary consideration when we went through the rules and regulations. Okay, that's where we are with those sections. Now, one of the things that I think that I'd like to do is, are all of you staying for the next behavioral health, or some of you leaving? Some of you are leaving. I'm going to step out in the hall, and if those of you are leaving, if you have questions, why, I'll answer those questions out in the hallway for you. The rest of you, I'm going to turn over to Brian, and Brian's going to take on all of the behavioral health components.
Okay, so as part of the behavioral health, then, can you answer a couple questions for me so I can tailor this a little bit? Are most of you a behavioral health licensed facility who wants to add services to become integrated, or are you the other way, where you're doing the physical health and you want to do some behavioral health?
We're currently doing services and grandfathered in.
Okay, so a lot of you are behavioral health wanting to add the integrated health. Okay. So a lot of what we're going to, not everyone, okay.
Can't get out of jail on this.
What you're going to see then is that a lot of this was just what was covered, okay? The behavioral health part of it, although it's changed a little bit, hasn't changed all that much, okay? But there are some drastic changes with it when it comes to kind of staffing and all of that stuff. So as part of this, we'll just talk a little bit. I'm not going to kind of read it line by line, but I'll go through some of the parts that have really changed so that you're aware of kind of this. And then again, if we'll hold the questions, once we get through this, then we'll open it up for Q&A for any questions for basically the behavioral health part of it, okay? So some of the stuff that we skipped goes back into where we were at in 10-11. So after that, we were skipping, but that's where you would find all of this stuff when it talks about behavioral health. Now, again, based on what Connie was talking about, the administrator of the outpatient treatment center that provides behavioral health services shall ensure that the OTC does not provide a behavioral health service the OTC is not authorized to provide. The behavioral health services provided by the OTC or at the OTC are provided under the direction of a behavioral health professional and comply with the requirements for a behavioral health paraprofessional and a behavioral health technician and an assessment. A personnel member who provides that is at least 21 years of age or at least 18 years of age and is licensed or is a behavioral health professional. Okay, that's changed a little bit when it comes to the age ranges, because we had a couple of folks who were meeting the requirements as say an RN or even as a BHP who were meeting those requirements prior. So these are folks who, I think about the only one that was out there is an individual who graduated like college when she was 14. So she was able to do whatever, okay? It doesn't happen that often. Now, as we're going forward, you're going to see there's a couple of major changes when it comes to the OTC parts of it. Part of it is the assessment, okay? The assessment and the time frames that you can use someone else's assessment has changed. Okay, it used to be if it was done within the past 12 months, now it's gone to 30 days. Also, if you're doing an assessment, if it's conducted by a BHT, within 72 hours, a BHP reviews and signs the assessment to ensure that the assessment identifies the behavioral health services provided. And if it's done by a BHPP, okay? In the past rules, that was not, you couldn't do that. When we get to the part where it talks about what BHTs and what paraprofessionals have to have, this basically says that if a paraprofessional is conducting an assessment, that a BHP supervises the BHPP during the completion of the assessment and signs the assessment. That means they're in the room. Okay. So again, there's time frames for this, and for you folks that may have a couple of different subclasses, so say you have an OTC, and say you have a residential, or say you maybe have an inpatient facility, part of a subacute, the time frames now are a little different for each subclass, okay? So when things have to be signed, so if an assessment is done, you need to make sure that you're looking at the right subclass to make sure you know what your time frames are for signing off on that, okay? The assessment itself really hasn't changed that much. It's still pretty much what it was. The one thing that did change with it is if you've read these rules well enough and long enough, you're going to see that as part of our minimum standards, that we no longer require a formal document called a treatment plan. Okay? Now we're minimum. Referral sources, contractual, all of that stuff may go above that. Okay? Ours are minimum. In these OTC rules now, it says you have to identify those services, frequency, method. You have to do that on the assessment. Okay? So that's where what's new is that you have to put on the assessment the behavioral health services, physical health, ancillary services that will be provided to the patient. Okay? So that's new when it comes to that. Okay? Counseling is offered as described in the OTC Center scope of services. And coming from behavioral health, you're probably familiar with what we had as a program description. Okay, we no longer have a program description. You're going to detail what it is you do in your scope of services. Okay. What that means is that you're probably not going to have a document that's that 15, 18, 20 pages, whatever your document is. As Connie was saying, some of the stuff you have to put into the application itself. So if you're familiar with doing a program description, you're familiar that you had to identify the clinical hours and the administrative hours. Well, they took that piece out of that and put it on the application. Okay? So when we're talking the scope of services, we're talking about the services you're providing and a kind of detail of what it is you're providing, probably who's providing it, depending on what kinds of services you're going to do. And counseling, that's the one thing that didn't change. That can still be done by a BHP or a BHT. Okay, the paraprofessional cannot do counseling still. Okay, you still have to verify the skills and knowledge for someone who's doing counseling, because part of your policies and procedures said you would do that. And secondly, you want to make sure that they're doing it safely. The counseling sessions, if you have that documentation, some of that's been removed. So I think what got taken out was like the duration. Okay, and we already talked about respite services. Now, is anyone in here going to be doing any of the DUI or domestic violence? Okay. Starting in October, that's where there's going to be some changes when it comes to the DUI stuff, okay? The department will no longer license the DUI, the 3 DUI services and domestic violence offender treatment. We're going to go to an approval process, okay? And that process is going to be laid out in Article 1, I believe. We're still kind of working on the process on how that documentation is going to come in, how that's going to be processed, but just keep in mind that that's going to be an approval. So unless it's a very egregious thing, we wouldn't come out, or the surveyors wouldn't come out to survey that. Okay, the courts are now going to be kind of the monitor for that. we will still keep the master list, the courts, that you're going to have the contracts with to provide those services. Okay. Okay. So as an administrator of an outpatient treatment center authorized to provide behavioral health services, that's the key. Behavioral health services keeps you as an outpatient treatment center, which means that even if you get grandfathered in as like a counseling only, that keeps you using the BHTs. Okay, if you're strictly a standalone, so you have the appropriate licensed individuals who can provide the DUI and domestic violence, you wouldn't even need our license. Okay, we would just do the approval. But if you're going to use a BHT, then you have to be an outpatient treatment center. Does that make sense? Okay. If you are going to have BHTs provide any of the services that they're going to be able to provide, BHTs don't exist outside of outpatient treatment centers or outside of a licensed facility that's providing behavioral health services. Those are just individuals. And the only people who can provide services are folks who are licensed. Okay, so through the Board of Behavioral Health Examiners. Okay. So the administrator of an OTC authorized to provide behavioral health services that requests approval to provide any of the following two individuals required to attend the DUI services or the misdemeanor domestic violence is approved to provide any of the services in subsection C1 may have a behavioral health tech who has the appropriate skills and knowledge established and procedures to provide those services. Okay. Now, as part of any of the OTCs, is anyone thinking about having observation chairs? Okay. The observation chairs are basically where you're going to set up a specific area in the outpatient treatment center. That service has to be available for 24 hours a day, and those folks are coming in for observation and stabilization services. So there is an identified need there. However, they basically are put into a chair and they cannot stay at the facility longer than 23 hours and 59 minutes. Because if they do, that constitutes residential kind of inpatient. Okay. So if you were going to do that, then there are specifics here on what kind of chairs you have to have, what the physical plant standards are for all of that stuff. And again, it's the 23 hour and 59 minutes. Okay. And if you're going to do that, or if you're thinking about doing that, you're really going to want to look at this section because it talks about the specifics of like a physical plant standard. It talks about how long they can stay. It talks about the skills and knowledge of staff, but it also talks about if you discharge and what the protocol is for if you discharge. So if you, as part of it, it says, except as provided in subsection A16, an individual is not readmitted to the OTC for observation stabilization services within 2 hours after the individual's discharge from the designated area in the OTC that provides those services. But that individual can be readmitted within 2 hours if it's at least 1 hour from the time of the individual's discharge and either law enforcement brought them back or the individual's case manager. Okay. And then it talks about if you're going to use an observation chair, or you can use a separate piece of equipment. But then it'll talk about where it's got to be, how far off the floor, And then there is a kind of a grandfathering in piece where it talks about starting in 2015, how much space you're gonna have in between the chairs. So it'll go to that 3 feet, but as of right now, they just couldn't get to that. So going forward, that's what we're gonna. And right here is where it talks about that. The other thing when it comes to the observation behavioral health is if you've been licensed as an OTC for a long time or even for a short time, you know that an OTC you can never do seclusion restraint, right? Okay. If you provide the observation stabilization services, you have the opportunity because the acuity of those folks that are coming in may require that. Okay, so then you're going to have to follow seclusion restraint standards. Now, do any of you do any of the Title 36 services? Court ordered? Okay. For the most part, because these were all based on statute, which is the law, you'll see in here when the current rules we're using, the Title 9 Chapter 20s, it would detail what that is and it would route you back to some of the statutes and all of that stuff. Well, here now we're referring you directly to the statutes. So, and the statutes really haven't changed that much. So there's really no changes when it comes to whether you're doing pre-petition screening, court-ordered eval, or the court-ordered treatment. Okay. And is anyone thinking about doing opioid, or currently doing opioid or methadone? Okay. When it comes to the opioid, not a whole lot's changed with that as well. So if you're currently licensed to do that, because of how federal law comes to that, and SAMHSA and all of that stuff, not a whole lot's changed. Okay. But again, this is where it's going to be policy driven. So when folks are kind of looking at their policies and procedures depending on how they wrote them for Title IX Chapter 20, just keep in mind that in Title IX Chapter 20 now, if you're referring to certain rules in Title IX Chapter 20, most of that's been repealed. Okay, the only thing that's in Title IX Chapter 20 now is the DUI and domestic violence. So that's where the difference is for an approval versus the license. Okay, so I'm just telling folks, make sure when you're looking at your P&Ps on how you're kind of routing yourself to certain rules, to take a look at that, because when Connie was saying it, we really deregulated what we put in there. If you remember in our rules, we had skills and knowledge that were A through O, and then you had to have the right person be able to visualize verbal interaction, that documentation. Orientation had to contain 6 things. You had to go into 408 to do your assistance in the self-administration of medication. This is it. So now it's in Title IX, Chapter 10. Okay. And again, pre-petition screening, it's all Title 36 services. Why they chose to put it in a separate section, not with the other Title 36. But all of that stuff is in the same spot. And then when Connie comes back, I don't know if she wants to go into detail about this, but that's where the contact information for the office is. And again, if you grab one of those cards, that's where the integrated help is. Sometimes, depending on how they get everything set up, sometimes it's a little difficult to find, but what you're looking for are either an OTC, so an outpatient treatment center, that'll be inclusive, or there's outpatient treatment centers that do counseling only, okay? And both of those, we did that training about 3 weeks ago, and I don't know when it'll get posted, but that's actually up. And as part of being an OTC, starting October 1st, we're not going to accept applications for a place that does outpatient treatment centers with counseling only. Okay, that's not meeting the definition as it stands now of a healthcare institution. Okay. These last slides, I don't know if you want to talk more about it.
Oh, no, I think you're fine.
Okay.